We've got a nice turnout, and people will still be coming on. I'm Rob Schwartz, and I run these rounds in general, and I'm the instructor for the two courses that these rounds are a part of. And as you know, these rounds are open to the general community as well. We run them once per month during the academic year. This is our second of 2020-21. And I'm delighted to have John McLaughlin with us today as our guest speaker. I just want to go through the format for those of you who may not be regulars. The way the rounds work is we devote the first 35 minutes to the keynote speaker. And then we generally go for a 5-minute discussant, a faculty discussant, and a 5 minutes for a student discussant. Today, unfortunately, we're not going to have a student discussant, but if any of you students want to pick up the rope and step in there during Q&A to do more of a discussion role, you are welcome to do so. And John, after discussant remarks, you may or may not decide to respond directly. Otherwise, we will go straight to Q&A. And the Q&A, we'd like for the students in the Collaborative Specialization in Public Health Policy to have first dibs on asking questions. And that's just to prevent a situation where they feel they get crowded out by anxious and active faculty members. So it's also a reminder to my students that it's your job to be asking important questions as part of this, to be thinking of questions. Each of you should have a question in mind as John is running through his remarks. So before I take up all of the time, I'm now going to introduce our speakers today. So my colleague, Dr. John McLaughlin is a professor in the Dalla School of Public Health. He is also the executive director of CanPath. That's the Canadian Partnership for Tomorrow's Health. It used to be known as Canadian Partnership for Tomorrow. He's an associate scientist at the Occupational Cancer Research Center, and he's a member of the Institute Advisory Board for CIHR's Institute for Population and Public Health. I'm not going to give you all of John's previous experience because that would take us probably about an hour, but he, amongst other things, was the Chief Science Officer and Senior Scientist at Public Health Ontario. And prior to a career at Public Health Ontario, he was a senior investigator at the Samuel Lunenfeld Research Institute, just around the corner from us. John has a degree in epidemiology from University of Toronto, and he has other degrees from Queen's University prior to that. So it's a real pleasure to have John here to speak with us today. I'm also going to introduce our faculty discussant. Dr. Michael Chaitin, a very close colleague of mine. Michael is a co-lead at the Ontario Tobacco Research Unit. He is a scientist at the Institute for Mental Health Policy Research at CAMH. And he is also a professor at epidemiology at the University of Toronto. Michael and I are close collaborators on many projects, and I owe him a great deal because if it weren't for his epi and stats capabilities, I wouldn't be able to do very much at all. Michael has his PhD degree in epidemiology also from U of T. And he has a long line of accomplishments in the area of tobacco control research and mental health research as well. So welcome to you both, and without taking up any further time, I have to do one more thing, and that is the land acknowledgement, which I am reminded I have neglected to do that as part of these rounds, and that's been a very bad thing that I've neglected until now. So just bear with me a moment as I call up the land acknowledgement. that I have prepared and almost forgot to give once again today. So my apologies for this little bit of a break, but I think that I'm going to have it here for you in just a moment.
While you're doing that, can I just check whether people can hear me okay? There's some loud machinery outside my window, so I've put on a microphone. Can you hear me okay?
Yeah, perfect, Tom.
Thank you.
Okay, so I would like to acknowledge the territory. We'd like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalla School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. Okay, John, please go ahead. You can share your screen and you have up to 35 minutes from now.
Thank you, Robert, and thank you everyone for participating today in the rounds. Just so I get a better sense of how many are actually students in the public health policy program, I'm not going to be quizzing you about whether you read the 4 papers or not, but just a bit of a sense of the numbers in the for credit course, Robert?
Yeah, there's about 30.
Perfect. Well, it's good turnout plus of trainees plus others, and I've been a strong supporter and partly involved in the program with Robert really from the outset. So it's a pleasure to have a chance to speak with you today. You can see the title of my presentation is Evidence, Investigation, and Determination Underlying Public Health Policy and Practice for COVID, and I'll give. Okay, why is it not advancing? Here's the outline of the presentation. In the 3 domains, I'll be giving some examples of some of the type of surveillance data that's been put to use and how this is relevant at the national, local, and international levels. Some specific examples of studies or investigations that have been done to actually contribute, to take us from data to evidence, and then I'll comment on some of the determined efforts that have been necessary to build what's presently available and help us prepare even for the next phases of the pandemic. In terms of disclosures of conflicts of interest, I have none. I am the co-lead of a project, which I will summarize, CanPath, which Robert has described, which was funded through a competitive national nature. All of the material I'm presenting today is in the public domain. I'm using the same types of things that each of you have probably been scanning, such as the following. These are data from Our World in Data. It's one of the widely used and really quite impressive international repositories of COVID patterns and trends. Here I'm showing the incidence rates per million people for several nations. In this drop box, I've sort of focused on the line for Canada, just so you can see where it fits in that. We are all watching the daily counts. As an epidemiologist, I tend to look at rates. Sometimes rates and counts are telling you exactly the same thing, but sometimes they're not. So that's where the focus on rates may come in. And then similarly, one can look through tools like this at mortality rates. Here you've got some of the sort of standard surveillance data, the same nations. Canada's mortality rate is popped out here, as is the incidence rate from the previous figure. The scales on these are, the scale for mortality is a tenth of that for incidence. So this incidence figure went up to 100 cases per million people. This is up to 10 deaths per million people. But you can see that the shape for Canada is really pretty much the same. And even though in earlier phases of the pandemic, we were, obviously concerned around the world about the nature of the pandemic, and that in terms of the numbers of cases, Canada was actually doing much better than some of our nearest neighbors. And even presently, that continues to be true. Epidemiologically, you may know as students that it's very useful sometimes to be looking at the log scale. This is on the log, plotted on the log scale, which tells us that what's really changing in terms of the rate of the disease and the transmission, better than just looking at counts themselves. But because it's on the log scale, you can see that a number like this for Canada versus our nearest neighbor to the south, even though these numbers look similar, because they're on the log scale, this is pretty regularly showing that Canada's rate has, or the rates of incidence and mortality in the United States have been at least 4 to 5-fold higher than those for Canada. So Canada has been doing okay. Could we do better? Of course we could, but no, we're not New Zealand. I've put New Zealand here for 2 reasons. One is because I've referred to a paper for the students to read. The reason for the notchiness of this is basically small numbers. So I'll come back to that in a little bit. Those types of data that are widely available through international sources have been put to good use by teams such as the Lee et al., who have published one of the papers that I circulated beforehand. Basically, they've taken data of that type from over 100 nations, and they've done an analysis of basically 2 things. One was the reproductive number, the R number, and one was the types of non-pharmaceutical interventions, or let's call them public health measures and interventions that had been reportedly done in several different in the parts of the world for which the incidence data were available. And then, given the nature of those interventions, they did some analyses that provided some evidence, such as here, for different types of public health interventions, banning public events, banning large gatherings, the types of things that everyone pretty well everywhere is now familiar with. But you see, when these types of interventions were first of all put in place, there really was no evidence because there had really been no pandemic like this before. The evidence about the nature of the public health interventions was really based on past experience. But even in the midst of the pandemic, with this paper being published basically a couple of weeks ago in the Lancet, October 22nd, they were able in the pandemic from January to July to study patterns in over 100 nations and to assess whether these types of interventions were having any impact or benefit or not. And these ratios of the reproductive numbers, for students, again, this is not your typical relative risk estimate, but it's a similar type of ratio measure. The fact that these numbers are less than 1 and significantly less than 1 was actually providing evidence that there were protective effects or reductions in risk associated with these types of interventions, especially out at the later time point, not necessarily at the early time point. And so this was just one example that has demonstrated reduced transmission associated with several of these types of public health interventions. At the national level, there's also lots of data available. I've given the sources for you to be able to link to, but it basically Health Canada, Public Health Agency of Canada, there are data resources that are bringing together the data from all of the provinces of Canada. And this is one of the dashboards that keeps a daily tab on numbers of cases, numbers of deaths, numbers of tests, etc. And then there are interactive tools like this map, which is based on some work done, in fact, by faculty here at the Dalla Lana School of Public Health, Ashley Tuitt, David Fissman, and group. But basically, quite early in the pandemic, they generated a tool that allowed for regions of Canada's data to be portrayed in this way. And just as an example, for the the Western Ontario or Windsor-Essex County Health Unit, that the detail for that small unit could actually be examined. Also at the provincial level, then there's evidence from the Public Health Ontario or the Provincial Public Health Agency, which is again counting the number of cases over the course of the pandemic in Ontario of COVID-19, and then going a step further by asking the question, well, under different scenarios of R, or the reproductive number, what is likely to happen past today and projecting out for short term into the future for different patterns of R. So this would be an example of some of the type of interpolation or modeling that could actually be done to prepare for what's coming next. So for the data, the surveillance data to allow us to generate evidence, I mean, there are some basic requirements. Again, these are fairly standard types of things, but it's worth going back to the basics to imagine, well, what do we need to make public health relevant decisions? Well, the data has to be accurate, available. We have to have it in for different places, such as cities, provinces, countries, to be comparable. The data do require they must be complete. You can't have holes in the data and a lot of missing information. And it needs to be standardized in such a way that we can make comparisons across person, place, and time, which are basically the key elements of descriptive epidemiology. There also need to be the information systems and tools, whether statistical tools or database tools, to allow us to access and analyze the data. And then the teams, the expertise, the resources have to be in place to make sense of the data. And there needs to be responsive systems that allow data and evidence to be constantly updated, because as everyone knows, this pandemic is changing on a daily or weekly basis. So data systems and tools have been established across many sectors, and they have been informing the pandemic response. And there are some things that we can do easily, classically, counting cases, counting deaths, but there are other measures that are obviously very relevant. Here's another publicly accessible site that many of you would have seen. It was developed really based on student initiative here at the University of Toronto, with the oversight provided by faculty, and then in many different faculties, I would add. So the site is called How's My Flattening, and their basic dashboard is showing for Ontario the presence of certain data that's been mapped out geographically. We can look at the counts of cases and deaths, which is the standard, but go further and ask questions about, well, how many long-term care staff have been affected? How many patients are in hospital? How many outbreaks are there in long-term care? What is the reproductive number for COVID presently in Ontario? You can see how that's been changing over time. What's happening with testing? And then even how mobile is the population? So some of the mobility data that's coming from outside sources. So this is an example of basically a dashboard that is very effective at capturing information from all of Ontario or the regions of Ontario. This map is now showing the City of Toronto Health Unit, and then basically any health unit could be tracked in the same way with similar types of patterns and data readily available, updated on a daily basis, and it enables decision-making at the local level as well as at the provincial level. So what are the things we should be measuring beyond those types of performance metrics for COVID? Well, this plot is again from the international data systems, but it's looking at excess mortality. That's all causes of death, not just COVID. That's not just counting COVID deaths. And this is important because there can be other factors that are happening in populations that might be more than the infection, the viral infection itself. You can see the peaks for certain nations such as England and Wales and Italy. These are very, very high peaks early in the pandemic, and then settling down. But we are all now at the second this new phase. Some nations have already had their second wave, others have not. The pop out here for Canada is showing that basically the data for Canada for this analysis have not yet been fully made comparable yet. So this analysis is, even as of yesterday, still only up to August. The point being that we are very interested all in knowing what's happening with all-cause mortality more recently. Other special sets of the population which are crucial to be monitoring, and everybody knows this story, but the long-term care facilities, long-term care residents are clearly at risk of more severe COVID infections. And so keeping and monitoring of the number of cases, the number of deaths in long-term care is shown in this figure, both amongst the residents themselves, but also staff member. The fact that in recent days and weeks, there is a reemergence of outbreaks in long-term care is deeply concerning. They were a concern early in the pandemic as well, but then things were really very much better controlled through the summer, as one can see here. Sort of other age-related phenomena are also important. Again, from Public Health Ontario, for Ontario as a whole, you can see that this is the type of thing that has been reported in the media quite substantially, that it is in the 20 to 39 and the sort of younger adult and middle age or earlier age, where the incidence rates now are peaking, are very, very high. There have been very high increases, especially in this 20 to 39 category. Again, indicating where targeted interventions could be made while trying to control disease which would put at risk the elderly or others who are more susceptible. That concept of susceptibility is extremely important, and in School of Public Health, everyone is familiar with inequities that occur across the system. The challenges are, it's easy to say we'll establish policy to address inequities, but how does that work? What's the evidence that we can do something? The New Zealand paper that was circulated is one of the results is shown here. This is actually a plot showing actually the amount of testing that occurred during the first 5 phases of the New Zealand first wave of the pandemic, from the very beginning, the very first stage until the pandemic or the spread in the community was quite high. They were just beginning to ramp up their testing capacity. The main point of this figure is obviously that over time, there was an increase in testing. But the key thing is that for different subgroups of the population, the Maori people, the Pacific Islanders resident in New Zealand, Asian ancestry, and then Caucasian, that in each group there was an increase, but in particular in the 2 groups that were seen early in the phase to be most at risk. And so the fact that they were able to deliver testing capacity in targeted ways to help address inequities was one of the targets, and it was actually shown, or that paper actually provided evidence that they were successful in that. So what is it that we need to do to transform evidence into policy and practice? Well, again, for all of the fellows, this is something that you know well, but it would be important to have the following elements. There needs to be a capacity. There needs to be collaboration, teams that can manage and maintain progress are needed, while managing the fatigue that occurs in the situation of a lot of people are working tirelessly to try to address the pandemic. We also need to be delivering innovations in how outputs are possible that were not previously possible. Basically, this list is things that I believe a lot of progress has been made in Ontario, in Canada, in many, many jurisdictions where the COVID response has been taken very seriously. Each of these things has progressed. Have we developed all of the capacity that we need? Absolutely not. It didn't exist before. It's better than it was, but there's more that we could do. Leadership is also needed to sustain the teams and set shared goals. responsive and adaptive efforts to adjust to changing circumstances are also needed. And then communication and transparency is needed. There's also a tremendous need for focus, determination, and initiative. And I'll give a couple of examples of what I mean by that. So in the past, it was actually very, very difficult for any one of the people on this call, myself included, to actually in a rapid way to gain access to some of the data that is useful to help drive public health evidence. The types of surveillance tools that I demonstrated at the beginning, those are great, but they're not completely sufficient. There's a need for more and to be made available for people with the skills to take this on. So one of the things that has been developed is the modeling consensus table. It's based right here at the School of Public Health. It's a way for scholars, professionals who have skills with advanced methods, modeling methods, to generate estimates of COVID-19 incidence, prevalence, and spread, really to help drive and support decision makers and health systems leaders in addressing the evolving pandemic. For this team to come together, we needed to establish a way to rapidly respond to the data needs, as well as to answer the questions that were coming. So modelers who don't have data can't do anything except things that are very hypothetical. So an effort has been made to actually make available data to the modeling consensus table members, who then are answering such questions. And then it's also leveraging the expertise in several of the organizations, the Government of Ontario, the Ministry of Health, the major health institutions or organizations such as Ontario Health and Public Health Ontario, but as well as the scholars and experts who are outside of those organizations. The modeling consensus table itself, this is taken from the Government of Ontario's website shown here. The modeling consensus table supports the Government of Ontario's decision making, which includes a science advisory table. Reporting up to those levels is this group of investigators. Some are computer scientists, mathematicians, epidemiologists, clinicians, clinical scientists, and leaders of various health organizations. So it's an example of a team that's come together in an interdisciplinary way based at the university to answer questions that are relevant to the pandemic and helping to guide policy for Ontario. For the students, I had shared the link to this paper, which was published in May. The authors, first author Ashley Tuitt, David Fissman, Amy Greer, are two are based here at Dalalana School of Public Health, and Amy's at the University of Guelph. At that time, published early, April 8th, the models that they were generating were asking the question, well, how many cases are likely to occur and what fraction or what number would likely require care in an ICU? This is plotted here per 100,000 population. One can see for different scenarios, again, this was published in April. So this was very, very early in the pandemic. This was helping to prepare for what might come. A base case was based on no interventions being in place. Orange is showing if there was enhanced case detection, purple physical distancing, and a combination of those two types of interventions. This figure is actually the same data as here, just an expanded y-axis, so we can see what was going on below. But basically, a model like this was indicating that case detection was not going to be good enough to actually allow for the volumes of ICU patients to actually stay within, and what are these dashed lines refer to the existing capacity or the stretch capacity in ICUs. So the only way to stay within that capacity of the ICU beds in Ontario, it did require additional effort. So this was a way for planning to basically support evidence even before we had much experience with the pandemic in Ontario. Another paper where the senior author is Beata Sander, who's the co-chair of the Modeling Consensus Table. This paper was pre-released in May, published in the CMAJ in June. So this was a situation of simulation models to basically, again, assess the healthcare system burden with scenarios based on Ontario's population and experience, and the experience that was actually seen in other nations with the spread of COVID based on their types of rates, patterns, and spread. What this figure is showing is that over the course of 2 months, 60 days, after there had been enough cases in the population for there to be some statistical precision to be sensible for modeling, the orange line is showing kind of the expected number of cumulative cases over all of Ontario during that time. The dashed line is the projection beyond the data itself. And what I've pointed out here is that there was the worst case scenario, kind of a best case scenario, and a projected scenario on some of the interventions that were feasible at that time. And the projection at that time in this paper was that at 60 days, there would be an expected 18,047 COVID cases in Ontario that would be the total number of cases, a fraction of which, in the paper it goes into more detail on this, would appear in the, would require hospitalization or ICU admission. Well, interestingly, I mean, one of the things you'll hear quite often is nobody believes projections because, oh, well, what are they based on? Well, for your information, I just went back to see, well, what actually happened? This paper was published in May. The data were available at the time were from this earlier period. The projection was out about, say, 3 weeks. They projected. This number was their number. And this turned out to be the actual. And I would say, bravo. They were off by less than 1%. So this is an example where, obviously, if you project out years in advance, that's tricky. But if one is making planning decisions in a reasonable cycle of, say, roughly a month or so, or weeks or so, these models can actually be quite accurate, very useful. And, you know, again, it's a model. It needs to be corroborated. It needs to be looked at again. But these types of papers can be very useful, especially in the situation where there's no other lived experience to go on. Another brief example that I'll mention is that Ontario has created what's now called the Ontario Health Data Platform, OHDP. You can go online and get the information about it. This is actually something that researchers can apply to access very comprehensive data from these types of data sets that are listed here. This is the first time this has ever been possible in Ontario for researchers to gain access to data in this type of streamlined way. And it's for the purposes expressly motivated by COVID, but to help the health research and the healthcare systems respond to COVID by providing data to researchers. And in particular, this was motivated by the major investments in many places around artificial intelligence, machine learning types of tools. So it was really that motivation and the initiatives that were investing in these types of initiatives. And yet, it only makes sense to have AI solve problems if they have real world data. And this is actually, these are the real world data that are going to be very useful for that, including the high performance computing clusters have been made available. And there's a very rigorous privacy data governance structure that's been going with that. So the current status in the midst of the pandemic, I'd say, well, agencies have established new mechanisms to make data available to researchers and other experts. The university-based researchers have really stepped up to address applied questions that are probably different than what they were focusing on in the research programs before the pandemic. There are a few who were already in that game, but now they're not alone. They're now supported by many others. The talent and resources from other sectors have basically come forward to offer support to the public health analytics capacity. And that's very important because there have been large demands and pressures on the very small and widely stretched capacity within the public health system. That continues to be true. It continues to be very much a pressure in such demands. It's been encouraging to see the collaborations across many disciplines and jurisdictions, whether it's at the local level or right through up to the international level. And much of the work that has been done has been based on volunteers stepping up. These are people who have another day job. These are people who are appointed for other reasons, and they've actually stepped up in many different domains, partly science, partly clinical, partly testing, partly volunteering to help with communications, analytics, data systems, you name it. That is encouraging. And then you all know that we're in this world of instant information. There are some pros and cons about that, because it's hard to actually maintain quality and comprehensive understanding of that. But regardless, we have instant flow of information. And the key thing is for scholars, such as through a program like this, to really help drive evidence to really inform policy and behavior. There are a few buts that I'd like to comment on. One includes everyone everywhere now knows about cases, the counts, and what happened yesterday, what's going to happen tomorrow. But what should we be measuring? And beyond cases and death, there are some other health consequences. So I'll give an example of some of the things that we could be looking at. Using the example of CanPath, which is a very large health research platform that stands for the Canadian Partnership for Tomorrow's Health. And with CanPath, it was possible to undertake a rapid response for COVID research involving Canada's largest health research platform. So in terms of research design, people should be familiar with how a cohort study is different than many other types of studies, especially a large-scale population cohort where people are followed over a long period of time, or it's a prospective cohort. So we start at the beginning where some measurements are taken and track people over time, where different outcomes are occurring within each person. And that's exactly what CanPath has done. It has become Canada's largest health research platform with over 330,000 participants in the data set that's available today. That number will be continuing to grow. Right now it's 7 cohorts in 10 provinces. All provinces of Canada are included, with a wide range of dimensions of information as shown here. The 330,000 people come from projects that are in each region of Canada. The total number of participants in each region you can see here. In Ontario, the Ontario Health Study has, in that data set, over 213,000 active participants. And then similar numbers in the other regions across roughly 30 to 40,000. The province of Manitoba is actively recruiting now, and we've just started recruiting in Saskatchewan. One of the key things of doing this type of work in Canada is that we can work with consent from participants. Data linkage enables participants' lived experience to be assessed in real time and over the long term. Thinking of COVID, for example, what is seen within their hospital or primary care records, or what is seen in the laboratory test data is extremely informative for monitoring the health of individuals. With a group of over 300,000 participants, it was possible for us to launch a COVID questionnaire. The COVID questionnaire meets the best practices of Canadian standards, but also allows Canada to collaborate with international COVID research efforts. and allows us to ask a range of questions. Some of the obvious ones, everybody who walks into anywhere is asked the questions about symptoms and have you seen anybody, are you sick? But how about those hard to measure things that nobody seems to know too much about? What is the impact of the pandemic on mental health, emotional stress, social, financial, occupational, living types of factors? These are impacts that data are not widely available for, and the existence of CanPath has enabled that to be done. So much so that this was updated the end of October, but you can see that we've already been able to receive back survey responses from over 95,000 participants shown in the provinces here. Some of these are still in progress. To do a survey in a pandemic of 95,000 people, where there's already rich data about who those people are, how they were living before the pandemic, and now how they're living in the midst of the pandemic and later, is a fundamental game changer. Here's an example of preliminary results from the Ontario component of that, and you can see that just in the analysis of the first 40,000 participants, some of the types of things that have been reported. This is actually a relatively healthy cohort. Note that we didn't start by trying to survey COVID patients. So the total number of people, or the percentage who tested positive or who went for testing, it's small, but this is a snapshot of what's happening out in the community, because these were people who were surveyed at home. And then this is an important part of it, that 22% reported that their mental emotional health is worse now than it had been before March 2020. So this is the kind of a new platform. Another key piece for a project like this is the ability to look at the biology of COVID. And this is where taking the, we've received funding through a couple of competitions for a project called Support Canada, where it allows us to look at the COVID data that we are collecting amongst CanPath's participants, as well as serological surveillance data. This number here is larger than the one I mentioned before, because the 330,000 is the currently available data set, but there are actually more than 400,000 participants in the project, and it will just take time for those data to be set up. And then on the biology side, there is interest in better understanding of the host and the viral genome. The serological studies that we've recently been funded to do, including funding from CIHR and funding from what's called the COVID Immunity Task Force. This funding was just announced last week. It allows us to send dry blood spot kits to people at their home, and we will be able to do a surveillance exercise to assess immunity status for over 20,000 participants in the CanPath cohort. So again, this is what everybody's hoping, that immunity is going to solve this problem, solve the COVID problem in Canada. Right now, there's no vaccine, but there will be in the future, but we really do need to be monitoring antibody levels and immunity amongst people where they live in the community, across many diverse communities across Canada. So in summary, I've just tried to give some examples of evidence, investigation, and determination that's been in place for the COVID response. There are many systems and data platforms and analytics and governance that have been generated through the pandemic, but I think it's important for it to also be known that when we're not in a pandemic, or when there's an off-peak period at the pandemic, those are the times when it's important to either strengthen or maintain or build those platforms. It's very difficult to do in the pandemic. Balancing the risks and determining optimal strategy is another key part of the challenge, the determination that's necessary, including measuring the things that are hard to measure and trying to address those. And then with the CanPath experience, here we have a cohort where those participants have been contributing data for a decade, since 2008, It took a decade before that to actually build up the possibility of doing that project. So it's taken a 20-year commitment to make something happen that now in a pandemic, we can really do something that's useful that could not have been done in any other way with any other tool or system in Canada. It's a wake-up call, I think, to the need for being prepared for pandemics by building sustainable systems and data flows in the good times and maintain those until we're in a challenging time. I'll just open it for discussion with Michael and others while thanking all of the participants across all of Canada for CanPath, thanking the sponsors and hosts of CanPath, and thanking you for your attention. And I should also thank all of the many analysts, scientists, trainees who have been making tremendous efforts to help control and respond to the COVID pandemic around the University of Toronto, but across Canada. Thank you.
John, thank you so very much. I'm feeling a lot better after your talk than I did before it. Let's see what happens in the discussion. Michael.
Thanks, Robin. Thanks, John, for an excellent talk. I also agree that this does make me feel a lot better. I mean, my interest is in mental health and addictions, and one of my projects submitted was to develop more monitoring capacity for mental health and addictions, particularly given COVID. I think it's clear that what we've done better in at least the 20 or in the years since SARS, where we first came to sort of the modern realization of the need for a sort of robust public health system, is the ability of the system to collect and systematize the data from the health system itself. Organizations like ICES and the reporting structures that have been put in certainly make it clear that we're able, in large parts, to be able to understand what the capacity is of the system, to have that automated fairly well. I mean, I think we always could do better, but I think that those are real sources of success in Ontario that we've seen. What we've been following, what we don't have, and I think CanPath is one of those sources where we helps fill some of the gaps, is the monitoring of individuals rather than of systems, and that we are also entering an era where the sort of traditional methods of of surveilling the population were based on things like telephones or door-to-door surveys, and that our structures for surveillance are also very much of the population are very much focused on from the chronic disease perspective, where things change very slowly, and that it is okay to have the Canadian Community Health Survey every couple of years, and that it is okay to have one every 10 years, the mental health supplement to the CCHS. So I think the question is of that source is, how do we move forward? In moving forward, how do we find new ways of providing that surveillance, of monitoring the population from this more self-report individual level? Is it in the systems like CanPath? Do we need more broader surveillance? Do we need more sort of cheaper surveillance, or is this kind of cohort sort of the more scalable to be the system that we have in place and need?
Would you like me to respond to that a bit? There are about 10 things I'd like to respond to, but I think your last point, I think, is the biggest individual question. Just to start with your introductory contextual comment, I agree with everything you've said. Basically, including that I didn't specify the importance of ICES data as an example. You know, for those of you associated with Dal Lana School of Public Health, including IHPME, that's the home base for the scholarship and the academic work of the remarkable data enterprise that ICES is. And I did mention the importance of linkage for our cohort, and it, you know, in Ontario, it is the ICES data, which is primarily what we're linking to. Interesting, just a little aside, again, for the trainees in this crowd, it's interesting to think of how Canada has that distinct advantage to be able to do such linkage. And yet, we have Canada with the BNA, the British North America Act, that says, oh, healthcare is a provincial jurisdiction, and healthcare in the provinces has created rules and regulations that said, but we don't let health data leave our province. Well, we want to do something national, and we want to break the artificial boundaries of geography. Not me, all of us collectively, we assume that there is some way of counting cases like COVID across international boundaries in a systematic and standardized way. So I think that COVID is really pushing the pressure on, let's find ways to overcome the artificial barriers to actually sharing information and knowledge across boundaries, whether it's city to province, province to nation, nation to global. Now, so ICS is a huge part of the solution for that, and we're working with them in a project to try to bring information across multiple provinces, because that's the nature of our project. We've got all of Canada in our network. Now, the mental health theme that you introduced and you commented on, what is the optimal solution for there to be meaningful, regular data about real people and their lived experience? Well, a cohort is clearly the optimal design. There's no question. It needs to be sustained over time. I will be the first to admit that CanPath as it presently exists is not the best way to study particular at-risk communities, because those were the very at-risk communities that it was difficult for them to be empowered or able or to participate in the study in the first place. But what we've demonstrated is something that was previously thought to be impossible because it was too big, it took too long, it was going to be too complicated. We've actually demonstrated successfully that yes, you can do this in Canada. And accordingly, just because it's hard doesn't mean we shouldn't do it. And at the same time, I think many investigators, policymakers are beginning to realize that the traditional model of doing a little study with a little patient group in a little setting wasn't really answering the big questions. It was a way for scholars to get a publication and graduate students to finish a thesis, and I'm all for that, by the way. But we have to think beyond the limitations of easy to do science. And that's why COVID is, I think, a great challenge. It's a hard problem to solve, but we can do it together. Evidence, data, analytics, collaboration, all that stuff is crucial. Mental health is a huge driver of what we need to be looking at in the context of the pandemic. Case closed. I'm with you completely, Michael. So we can talk about how we can work more and maybe even just use some of the tools that we've been able to deliver across every province of Canada. And maybe they could be adapted to help with something that really dives deeper into mental health challenges, supports, outcomes, and transitions. So the key thing, I think, for all of the participants here is to realize that just because something's hard to do and it takes a long time to do doesn't mean don't do it. Just find people who you can do it with. And again, I thank Mary and Eric, who are on this call, for sharing the early vision that yes, that cohort platform was worth doing in Canada. And 10 years later, it's completely real, and it's now helping to solve the COVID problem. So thank you. Did I answer your question, Michael?
Yes, you did. I mean, I think that, I mean, I just maybe to build on that last point about the sort of the platforms. I mean, you're able to, quickly recruit and survey 95,000 people, which is an impressive number. And I think that the other, so Jürgen Rehm at CAMH, he has been involved in a number of studies in Europe where they have surveyed hundreds of thousands of people, usually using sort of online panels or recruiting people online. And this ability to, again, it misses important parts of the population. So it's not a full solution, but it able to access large numbers of people than were previously thought possible for relatively for pittance, sometimes for almost for free, working off the back of people's desk. And that those are the kinds of tools that we need to make sure are in place, sort of that can be in place on a consistent basis so that we have them before the next disaster, before the next pandemic starts.
Sure. Thank you for that. One thing I didn't include in my lecture, but given even what you've been saying, Michael, I would like to add, the data that we've collected are not for me, they're for you, they're for everybody. So for example, we aim to have cleaned the data from those surveys and be able to post them by December. Whoa, that's next month. We've got some work to do. But the point is, the data are to be accessed by the Canadian research community, and that's who we've collected them for. And we need experts such as yourself, Michael, and your colleagues, others on this phone call. It's actually a public resource for people to, pitch an idea of, this is the question I have. We do have an access process, which is quite strongly based on the academic model, meaning that if you're doing it through university studies or a research university-based appointment, the data are available for such academic research. And so I believe that there's some value in these data being collected now, but then also analyzed by people who have the expertise on the various scales that have been used. Again, as Mary would remember, we worked very hard to ensure that the baseline questionnaires were including some of the world's best, most standardized scales. So we have a baseline, including the depression and anxiety scales that can now be, they've been repeated in the most recent surveys. So, and it's not just about mental health, it's about the other dimensions and impacts that are also important in terms of social determinants, even within the context of a cohort like this. When you have 100,000 people responding to a questionnaire, there's a lot of variation within it that we now hope the research community can take advantage of and make good use of.
Okay, I want to step in. John, thank you once again. Michael, thank you for raising those really important discussion remarks. I want now to open up the discussion. And the way that we're going to do this is you can either write into the chat, which a couple of people have done already, and I'm going to get to that. Or you can raise your hand, and I will try and see your hand raised through the system. I just want, as people are starting to do that, a couple of people have raised the issue of First Nations and Inuit, who are under the federal health funding responsibility, and therefore it's an important exemption that needs acknowledgement in terms of, John, what you were mentioning earlier about the provincial jurisdictions on the data, I think. So I don't know if you wanted to address that.
Well, it's again, it's what I find interesting in my career is that if things are easy to do, then I'll let somebody else solve them. The fact that it's been hard to do, to overcome those provincial jurisdictional boundaries, that's made it an interesting challenge. And in fact, it's not something that I need to lead, because there are other experts who are responsible for those domains who now understand or who share the same vision that I have. There's an initiative that's been funded by the federal government called the Health Data Research Network, HDRN. Michael Schull at ICES, who's the president and CEO, and his equivalent leaders of provincial data systems across Canada, they've actually been funded to overcome that barrier of being able to have data from one province looked at by someone from another province. Now, technically, this is an exciting time in the same way that I mentioned cloud computing a little bit before, or high performance clusters anyway, but cloud computing is a solution to this because you can actually leave the data in one place under the authority of the data custodian, and you don't have to move data around anymore. It's fantastic to be able to overcome that traditional barrier where people would say, oh, well, we can't move a data file from Ontario or from Alberta to Ontario or vice versa. So we've got solutions to that. And we've got a pilot study involving two questions. One is a breast cancer research project, and one is a COVID research question, where we're demonstrating what can be safely done with modern technology, rock solid data governance that leaves the privacy issues under the control and authority of the provincial privacy people, et cetera. So we've got solutions to that. It's taken longer than I would like to have actually been able to deliver that. And Eric Holowati knows very well how much over our whole career we've been trying to deal with. How do we get things going from one province to another, even with something like a cancer registry? And Eric, I'm still kicking away at that. So thank you for your early guidance on all of those privacy rules. Now, there was another part to your question. That was...
It was about the First Nations and the Inuit.
Thank you.
How that applies to them.
This is hugely important. Thank you, Diane, for raising that question. I see that Laxi Johathison has also commented on that. I'm delighted that Laxi was actually able to do during her MPH a practicum with us and with the Wakabines Bryce Institute for Indigenous Health here at the Dalawana School of Public Health, and that co-led with Dr. Suzanne Stewart, Laxi did a very, very thoughtful background paper to look at what are the issues around Indigenous health research in this type of population cohort that we have in CanPath. Now, many of you who have been working, and Diane, I'm sure you know this, that the whole issue around Indigenous health, in my career, it's actually been encouraging to see how much progress has been made in this field. You know, it started off many years ago around OCAP, but more recently cultural safety, the other dimensions of leadership, control, authority, and ownership of data, and not just data, of studies, and having the leads of a research program to be within an individual group that is being studied. So with regard to the First Nations questions, first and foremost, and Laxi summarized this very nicely in the paper that has been reviewed by Canada's top leaders in Indigenous health scholars, including the CIHR Institute director. She contributed very insightful comments. Well, fortunately, there are other mechanisms now in place to enable cross-Canada Indigenous health research. And so our project is collaborating with them, or let's say supporting them in doing their work. And that includes that the same agency that's funded our immunity testing, that's the COVID Immunity Task Force at the federal level, they have also established for Canada something called the Canadian Indigenous Health Circle. It's an advisory body or advisory circle. And that's the group that does have representation from regions across Canada that we're working with to actually enable there to be solid research in this domain. They are committed to doing COVID surveillance across First Nations, Indigenous health, Inuit, Métis, etc., across Canada. and we will support them in doing that because we've got the teams, the tools, the biobanks, the labs, the online questionnaire, whatever they want. We can adapt our online questionnaire, and they can go quickly, and that's ready to go. It's fed information back to us already on close to 100,000 people. Now, so there's a lot that can be said about Indigenous health. I'm a strong proponent of making sure that that is Indigenous-led, directed, and that we're here to support them. Diane's point about it being an under studied area, true, it is partly the federal jurisdiction, but I think it's more than that. I think funding can be made available. It's just needs to be designed properly. It needs to be Indigenous-led, and that's exactly what's happening now for the purposes of the COVID controls. There were press releases over the last 24 hours regarding some of the investment that Statistics Canada has actually been making in this way, that they're aiming to do surveys in each region of Canada, including 1,000 people in the Northwest Territories. Some of those people will end up being First Nations or Inuit. I don't know how they're going to deal with that in their survey, but we're quite committed to working with the Indigenous Advisory Circle to make sure that what happens in our domain of work is really what they need to do. So there's a lot more we could talk about there, but it's a good question. I think we're managing it. And again, if people are interested in these particular domains, maybe there's ways for them to get involved in CanPath itself.
Thank you, John. I want to, again, open up for additional questions and comments first from the students. And perhaps people would like to direct the conversation a little bit more towards the surveillance systems and their connection with policy. As I see that there is some chat going on, but do we have any questions on the floor from the students? You can put it either in the chat or by raising your hands.
I was wondering if I could just interject. I have a question about that link between monitoring and policy directly. And I think that you've shown wonderful data, and we have a number of really talented advisory groups that are providing guidance to the government. We've seen, that just came out in the last couple of days, the sort of the notion that sometimes this guidance has not been followed. And so I was wondering about that process, and I was, particularly wondering about sort of the value of independence in institutions like PHO versus sort of independent boards, and if you could talk about that translation between sort of evidence to policy directly.
And I'll just add to that, Rachel has just posted the link in the Toronto Star about the government of Ontario rejecting the advice from its own scientists.
So with regard to that last point, including, I haven't read that article because when I open up the Star, it says I have to subscribe to it or something like that. So I could only see the headline in the first paragraph. So, but there's been enough kind of other, so this is just a kind of a general statement that I'm making. People have asked me about the fact that the province ignored the advice of the modeling consensus table. Well, in fact, they didn't ignore the advice. They just didn't ask for it, and they didn't get it. So there's a difference between ignoring something and never being involved in a dialogue, which comes back to Michael's point. Like, how does one actually make sure that there is the dialogue, first of all, and that the questions are clear and that the evidence answers the question? Maybe let's call it a good thing that the pandemic has put people on the edge of their chair and they're ready to talk, or they're ready to be engaged. And now, does that mean that the conversations are completely linear in logic? Well, no, because there's the parallel pressure of there's just so much going on. And did you notice that, but even though I did say very nicely that lots of people have become engaged, have you noticed how it seems that, did we clone our dean of the School of Public Health? Like, he's everywhere, right? So isn't it amazing how there are just a few people that this is all riding on? That's a serious problem. Like policy questions, evidence coming in, this is actually part of the challenge. How do you make sure there is a linear, coordinated path from evidence to policy that involves dialogue? Well, in fact, even you might be talking to the wrong person. That's happened to me quite a few times on this. Oh, I thought we had complete clear understanding on this, and then oops, somebody else made the decision. And I'm not putting any blame at all on the provincial, local, or federal government. This is just the name of the game. There's a bit of chaos and commotion in the midst of a pandemic. There are decision-making systems, leadership structures, essentially part of an emergencies measures approach. Those processes do exist, but there's so much interest, concern. Oh, I mean, another way to say it is like, isn't everybody an expert epidemiologist now? Like, I don't know, like, everybody's looking at the same data, and if quite often I don't know who the epidemiologist is. For a while I thought I had trained most of them, but now it's a completely different world. So there are many parts to the challenge, but I do put it into the category of systems need to be in place where there is responsibility and accountability, so we know who's making what decision, and then that's where we want to get the data streaming into. And again, I give tremendous credit to the people who are crucial in the one group that I put the slides up for, the modeling consensus table. The other one is the science advisory table for Ontario. Staney Brown is a co-chair with a couple of others in that domain. They're working very, very, I'd say, effectively at trying to create a place where those discussions can happen. So the discussion gets debated, and then that's where I feel that there has been very good progress made. Some of the commentary in the media or on social media, it's actually not part of that organized decision making. I mean, and it's because everybody is welcome to having their opinion, and everyone can look at the data and make their own call. But it's we have to take things with a grain of salt. One of the other points I might have made about the students reading the New Zealand paper is, would it be a little different for us to have the dialogue around COVID response if we were an island like New Zealand versus having who our neighbor is, right? That's actually made our discussion a bit different than New Zealand's discussion. Any island nation had an easy thing. They could close the borders and they could stop the pandemic. One of the sources of information that kind of muddiness, I would say, is our nearest neighbor is not the stellar example for us to be modeling our behavior on, and yet that is a dominant influence in Canada. For what it's worth, so a lot of it's good, but sometimes it makes things complicated. Our politicians and our leaders are not affected by that, but it is part of the noise in the population, in the media.
So, John, there are a few more questions. I'm just going to go to the one by Raju. Excuse me if I'm mispronouncing that. But it's about how scientists and advisors can move forward with science communication to accurately portray information about the pandemic. And this was a question in my mind as well. Like, are there challenges here of health communication? Mm-hmm. To what extent, you've portrayed nice graphs, and most of us can understand them. Are the policymakers actually misunderstanding or having trouble understanding these things?
So it's a great question, and all of us are bombarded by the information that's coming from so many types of media all the time, and you know, as I said before, everybody's an expert, and it's now possible for all of those expert opinions to be tabled or circulated quite widely. From a formal process, one of the reasons I highlighted for you today that modeling consensus table is that it is a unique model. This is a situation where the university-based researchers come around a table and they debate like every Wednesday. Here's somebody presents their data and they get immediate feedback on Wednesday. And sometimes the science advisory table, or what was formerly called the command table for Ontario, sometimes they would be so interested in that they would actually be receiving it later the same week. So that is a model where you don't usually see the universities being the place where bodies like this are convened. Sometimes they're in a more public agency, Public Health Agency of Canada, Public Health Ontario, something like that. So this is a slightly different model, and it is partly for the reasons that Michael and Raghu have both raised, and that is, how do you actually get that evidence? And then, let's say from an academic scholarship perspective, we believe that there's some value in having some debate. We don't maybe debate enough. We can debate more on this call if you'd like, but debate and response, it is actually what peer review used to be really good at. You'd get really good constructive criticism through peer review, but it's happening in real time, and the high speed and the rapidity, that's essential in a pandemic. So the solution, I think, is partly that kind of model. The reason it works is because there's a way to maintain accountability. I didn't say too much about this before, but how do you actually distinguish between something that hits a very high standard of quality and rigor while controlling conflicts of interest, you know, making sure that there's integrity in the process? So this is where the university setting's really well placed. We set up that modeling table with terms of reference that said the university's scholars can get data if they are willing to work on these applied research questions, and then they're communicated directly through a science advisory table to the province. So that is part of the solution to the questions that you've both raised. Communication and transparency is extremely important. Nobody's perfected that, and the communication and noise in the system is part of the problem. That who's got the right answer? You know, everybody's can have their own opinion. Even every academic has academic freedom to, but the beauty of the academic model is there's a responsible conduct that each professor is to follow. And those responsible conduct rules help us manage things like conflict of interest, you know, personal interest, who's going to benefit, who's at risk, and then scientific merit and quality. Where else do you get that? Like, you know, I think it's partly true in government agencies, but they don't have the academic freedom. That's one of the nubs for this. And there's, in a situation of a pandemic, where nothing existed 8 months ago, and now we need high quality, rapidly responsive science. I think that kind of mechanism is necessary. And and then finally, all of us, I'm sure, just as I introduced at the beginning, I start my day, I go to how's my flattening, right? There are some tools and systems that I find are useful, and I trust them. Probably each one of you have a preferred sort of reporter or place where you might go for your trusted data. I think that that's part of the solution too. It's not as simple as communication. It's actually creating networks of trusted go-to sources. And for each one of you as a trainee, that will be part of your journey, is finding the place where you know that you trust the evidence, and then you yourself will be the trusted person passing that evidence on to others.
So John, Michael, there's a couple of notes in the chat about the collection of race-based data and the use of that, both sort of pros and cons about it. I'm wondering if either of you care to address the challenges that may be posed by having what one person is calling a racial tracker, if that may be misused, and perhaps the advantages of having it.
Yeah, Michael, I haven't given you a chance to say much. Do you want to start?
I mean, I think this is probably more aimed at you. I would say that I mean, there's always the balance. I mean, this is the you know, the importance of health privacy, and that would, you know, distinguishing the aggregate data from the individual. That, you know, that in some ways we're doing better because of some of the more electronic systems that we can disaggregate. You know, I think one of the sad things is the lack of success so far of the government of Canada's COVID tracker, that would have allowed sort of anonymous tracking rather than sort of individual level. And you know, that I don't have much to say beyond that.
Yeah. So first of all, great question. Of another place of really important sensitivity that's necessary from scholarship, evidence generation, public health interpretation and application does relate to not just race-based data, but racism. Like, we can call it that. You know, is there racism in science? Is there racism in the way things have actually been, first of all, perhaps measured, but then acted upon? So, you know, it's maybe that's a bigger thing than, it's certainly not a CanPath issue. It's a bigger issue for all of modern science to be able to take on. And it's sort of a funny way to say it that way, but, you know, what's the driver? It's actually not even going to be science itself. It's going to be ethics and other controls related to how our institutions generate evidence and then apply it. Now, from a CanPath perspective, one of the key elements is that every single project that gets the CanPath data goes through ethics review. So if somebody is asking for information that would be focusing on a race-based analysis, they would certainly need to address that in their own ethics review and approval. Is that a completely sufficient control? Not really, but that's also why, where there are other standards, such as the Indigenous health work that I mentioned before, we are fortunate to be able to partner with the leaders and those who are responsible for ensuring the quality and integrity and relevance of those types of things. Now, from a pandemic perspective, there is also something very important in that question, because we've all heard that there are certain pockets where the transmission, I would almost say, is unavoidable, because of, sometimes it's the social determinants which themselves may have become part of be sort of amplified or present because of racialized circumstances. So I would say that, yes, that's an important ongoing question. It's not something to just basically say, no, don't go there. I view it again as one of those important things that needs to be addressed, because in fact, being able to improve health and decrease risks amongst those high risk settings is crucial. And, you know, is it, if recognizing it as something that's been racialized is part of that solution, I think then it's worth taking on. Robert, there are so many comments in here that I'm not sure how to get through all of them.
I'm trying to curate for you. So there's one of the questions is about cost effectiveness, and whether we have good cost effectiveness studies about COVID related interventions. I think the context of this being the the proclamations by some policymakers and some politicians that, well, we need to have a balance between people's mental health, for example, and protecting the public. I don't know if this is in your bailiwick.
Well, it's not really my particular expertise, but the whole concept of balancing risks in this particular situation of COVID, I don't see it being a balancing of risks and benefits. I see it being balancing risks and risks. You know, there are just so many different dimensions where there's risk across all of these different dimensions, and then finding a way to so it's not really a cost benefit at this stage yet. That will eventually be done. There will be nice papers on that, but it will. The big costs are really much more the economic impacts, and that's. It hardly even needs much of an analysis to, in kind of in a scholarly way at present anyway. But fortunately, there are people who are certainly carrying that lens. I mentioned the co-chair of the modeling table, who's published quite substantially both COVID models, but is Beata Sander, who is an economist. You know, she's a PhD economist, and she specializes in health economics, and she specializes in population health economics. Wow, are we ever lucky to have her as part of the Dalla Lana School of Public Health? Because that's exactly the type of economist you need in this type of pandemic. Now, even Beata, who has published beautiful, thoughtful cost utility, cost benefit, cost effectiveness analyses, she's published papers like the one I put up for the students that hasn't bothered to cost things financially yet, because just counting how many people are dying or getting into long-term care, that is by definition a good enough measure of cost. But I think the reason for the question is it's actually more profound, and I respect what you're getting at, and that is there are certain forces that are very, very strongly pushing for just let the economy prosper, and then, you know, we'll take the consequences. And that does include our southern neighbors, and that message gets carried very easily across into Canada. And there are studies that have been published, and Peter Donnelly, who was previously the CEO of Public Health Ontario, he early in the pandemic summarized these very, very well publicly, which was basically indicating the costs to economies and people are very much in the negative, like they're very opposed when you just let a pandemic take its course for the purposes of stretching the economy, that controlling the pandemic, getting people, protecting lives, protecting families, that in previous settings, those papers and descriptions have been made. But really, presently, that's formal cost benefit analyses are not really germane. We should be focusing on saving lives, you know, helping, you know, keeping the balance, though. I think that's the key thing, balancing the risks. And if the risks include such as things as mental health, or some people living in isolation, or children, child development through education, those are meaningful costs that need to be factored in and weighed against what some of the controls have been doing. I was referring to that a bit by saying that the easy thing for us to try to act on is decreasing the number of cases. Well, that's because it's the easy thing to measure. It's like the story of a person looking for their keys where the light's shining. You know, that's, you know, the keys were over there, but they're looking here. Well, that's because the data are there and it's easy to measure. It might be that it's not a sufficient measure, because we should be looking at the other illnesses, the opioid-related adverse outcomes, the tragedies that are maybe under the radar presently. I think this stage of the pandemic, we're going to start counting those, and that's partly why I put up the figure about all-cause mortality.
Okay, John and Michael, I want to thank you both tremendously for, John, a very thoughtful and thought-provoking presentation, and both of you for also really wonderful extensive and comprehensive answers to some challenging questions. We've only managed to be at the tip of the iceberg. Clearly, there's so much to think about and talk about related to surveillance and COVID and policy making, but this has really been helpful. So thank you all. We will reconvene in January for our next round, so keep posted. By the way, Beata Sanders is a graduate of the Collaborative Specialization in Public Health Policy. We're very proud of her, and she's doing tremendous work. Yes, John.
Just one little thing. There's a couple of questions that people can get answers to by going to the CanPath website, including that the CanPath questionnaire is listed there. There's a link to the data content of the CanPath questionnaire. There's a lot of work that's being done on the environment side, as raised by one set of questions. So, feel free to contact me if you have other questions.
Okay, thank you so much, everybody. See you next time.
Thank
Bye-bye.
you all. Thank you. Take care.